Thanks very much, Abby, and thank you, PPMD, for the invitation to talk to you today about our anti-myostatin program in Duchenne muscular dystrophy. So my name is Binks. I'm the clinical lead for this program, and I'm here representing a significant team of people at Pfizer who have been working on this program for many years. So the first big news from us is that I no longer have to say PF06252616 every few minutes in this presentation. We have a generic name for a compound, which is donnatricimab. Donnatricimab. Is it better? Well, I think it's slightly easier to get your tongue around. Okay, so what I want to do this morning is just to remind you of some of the background information about the biology and the pharmacology of our compound, talk about the clinical trial design, and then give you an update on current status of the study. Before I do that, I need to show a disclaimer in terms of forward-looking statements. So I'm sure by now this community is very familiar with the biology of myostatin. It's been discussed as a potential therapeutic avenue for more than a decade, and you've, I'm sure, heard many explanations of the biology. But just in case it slipped your mind, myostatin is a small peptide hormone that's produced by muscle cells and signals back to muscle cells with a function of inhibiting muscle growth. So it's a normal physiological regulator of muscle growth. It binds to a receptor called the activin R2B receptor on the cell surface. That receptor also binds to many other small peptide hormones that signal in slightly different ways. But the signaling downstream is a cascade, particularly activating, phosphorylating the SMAD transcription factors, which play a role in regulating gene transcription and muscle protein synthesis. There are also pathways downstream of the receptor that actually are involved in the degradation of muscle synthesis. So at a molecular level, those pathways are quite well understood. At a cellular level, it would appear that myostatin works at different stages of muscle cell development. In the production of myoblasts and the proliferation and differentiation of these cells into myotubes. So just to recap, this is an inhibitory mechanism on muscle growth. And the therapeutic hypothesis that emerged quite soon after the description of myostatin as a regulator of this kind, really from gene knockout experiments, was that if you inhibit the inhibitory mechanism, there may be a beneficial effect on muscle growth, and muscular dystrophy researchers early on thought about this potential, and you can see that these two studies go back to 2002, so some time ago. So I'll talk about the panels on the left here first of all. So the intention was to evaluate the genetic ablation, the knockout of myostatin in an MDX mouse background. And the observation over time as the MDX phenotype developed was that there did seem to be a difference in muscle quality, and particularly the degree of fibrosis and fatty replacement that were observed in the MDX muscle. On the right panels, we see a different set of experiments where myostatin was not genetically related, so it's been present in utero and at birth in mice and for the first few weeks of life, but then it is removed from the circulation with an antibody to myostatin. And again, the observation over a period of time is that the quality of the MDX muscle appears to improve, and in particular, the degree of fibrosis and fatty infiltration in the muscle is reduced. The reason I want to separate these two observations out is that there are quite clearly some differences in genetic knockout of this hormone from birth, or from before birth, and a later intervention removing myostatin. And this plays out in a number of ways in trying to interpret the biological data of this pathway. In particular, we often get asked about the long-term consequences, and there are some data looking out at MDX animals over quite long periods of time for their lifetime. There's no obvious deleterious effect that we can tell. In particular, people are concerned about stem cell exhaustion. That it may be in the Duchenne disease situation that the high rate of stem cell production may simply deplete the possibility to regenerate muscle. The second concern that's sometimes pointed to as some observations in a genetic knockout in the dog model, where over a long period of time there seems to be an increase in tendon contracture. And this isn't seen, unfortunately the data are not yet published, but Lee Sweeney has treated animals not with a genetic knockout of myostatin, but with a therapeutic intervention over long periods, and that phenotype will simply not emerge. Okay, so let me talk a little bit about domaglosimab. Oh, there was one more thing that I wanted to say about two previous attempts to interfere in this pathway. Firstly, Wyeth, as a company, developed a neutralizing antibody to myostatin, and it went into clinical trials, not in Duchenne muscular dystrophy, but in some other muscular dystrophy, and produced some pretty marginal efficacy effects, but in a very underpowered small study. We've learned from that experiment, and the current molecules that are being progressed both by BMS and Pfizer are significantly more potent. The second experiment was a clinical trial conducted by Cellular in the late 2000s, where a safety event occurred with an increase in nosebleeds and a particular kind of skin rash that we believe is related to the inhibition of GDF2. So again, the current myostatin inhibitors have been engineered to ensure that they don't have that activity. So domaglosimab then is a neutralizing monoclonal antibody to myostatin, also called GDF8, that has a low nanomolar potency and is produced very easily and at scale in well-established systems. There are many licensed drugs that are monoclonal antibodies. So we've evaluated this antibody in the MDX mouse model, And you can see here on the top left evidence of an increase in lean body mass and of an increase in muscle weight. Very similar to wild-type mice, non-MDX mice. So that's a fairly clear pharmacological effect in the mouse. After the last session, one of the questions was focused on how does this mechanism impact strength? And while in both studies we're still waiting to see in Duchenne how it will impact strength, certainly in the MDX mouse model, not only is there an increase in muscle mass, but very clearly an increase in muscle strength, as you can see in the bottom panel there, as measured by grip strength in the MDX, of about 2% in this case. So we went on to evaluate the pharmacology in non-human primate species and demonstrated very clear dose responses on the increase in muscle mass and lean body mass, which was a fairly rapid onset over several weeks and sustained for quite some time after the cessation of treatment. We also looked on imaging, both by MRI and CT, to demonstrate an increase in muscle volume after 8 weeks of treatment, a clear dose response again. The antibody went into phase 1 clinical trials, and I've reported on those results at this meeting in the past, but probably the most important piece of pharmacology that we can show is after 3 doses of treatment in human volunteers, there was a significant increase in the proportion of muscle that was muscle and not fat. So this is a sort of precursor of the fat-free fraction. So a significant difference after 3 doses, extending out to 4 months after treatment. So this gave us enough encouragement that the pharmacology that we observed preclinically was being translated in the clinic. And we went on to devise this study that I'll talk you through in a moment. This slide will be up for a little while, so you have time to absorb it, because I know there's a lot of information. So first of all, we've chosen to look at a population of boys in the age range of 6 to up to 10 years. They have to be able to walk, and they need to be on a stable dose of steroids for 6 months in order to enter into the study. Notably, there's no requirement for any genetic restriction other than the diagnosis of Duchenne muscular dystrophy. The drug is formulated as an infusion that's given intravenously into the arm over a 2-hour period, and that's administered once a month. So for this study, boys have to attend their investigational site on a monthly basis, and obviously the travel and costs incurred by patients in doing that are paid for by the company responsible. So the randomization scheme I'll just explain now. So as the boy enters the study, he will be randomized into either receiving active treatment or placebo. He's twice as likely to receive active treatment than placebo. And then after 12 months, there's a switch around in which those boys who have received placebo for the first year then receive the active treatment. One of the groups on active treatment carry on the highest dose, the highest dose for the next 12 months. And the third group are then switched to placebo from active. We've had some concern about that last change, But in fact, the drug has quite a long half-life, and for most of that time, it will have active drug on board. But it does give us some very critical information about immunogenicity that we can obtain in that setting when the drug is gone, and also the offset of any biological effect. In order to, because this is the first study with this drug in patients and in children, we are dose escalating through the study. So boys are monitored obviously every month, but there's a safety review in every individual case after every 4 months prior to escalating the dose. And that's quite a complex procedure, but actually it's gone very well, and we're not aware of any boy who hasn't escalated up to the high dose in this setting. So from a safety perspective, right now, I'll come to it in a moment, things are looking good. The boys entering the study every 2 months are evaluated for a range of functional assessments, including the 4-stair climb and the North Star and the 6-minute walk. And every 4 months, they have an MRI of thigh to measure volume and muscle quality as measured by T2 and Dixon. The intent is that after 12 months on treatment, there will be a primary analysis conducted, and our primary endpoint for this study is the 4-stair climb. And if that is successful and there's a positive outcome, we have some understanding with some regulatory authorities that may be an avenue for accelerated approval. After all the boys have finished 2 years of treatment, there will be a secondary analysis which will provide us with a second data set to hopefully reinforce initial observations from the primary. Throughout this study, the safety data are reviewed on a quarterly basis by an independent external data monitoring committee that review all of the detail in an unblinded fashion. Obviously, the project team and investigators and boys are not aware of their allocation. We have an open label extension study that is setting up currently, and we expect to enroll the first patient in October, November this year. To allow those boys who want to continue on treatment to switch over into an open label treatment regime. And there'll be ongoing safety and efficacy monitoring in that study. Okay. So the current state is that we now have 57 boys randomized in this study. 14 of them have completed 1 year of treatment. We've had one withdrawal from the study, and that was really for social rather than safety reasons. We're not aware of any safety adverse event pattern of concern, and there have certainly been no serious adverse events. I wanted to make you aware of a study website that we have active, which gives a lot of background information to the study and what the requirements are for enrollment, and some detail about the various investigations that are performed throughout the study and their timing. We have a kids corner that is designed to be accessible for boys in this sort of age range, and we have an up-to-date enrollment barometer so that you can check how we're getting on with recruitment. Okay, so that's really all I wanted to cover today. I'm very happy to take any questions about this study. Thank you. Now, I'm glad that Leslie drew all the difficult questions.
I have one question. So during your presentation, I thought I heard you saying that this trial is for boys up to 10 years, and I thought I saw on the slide it was less than 10 years. So could you please clarify, is it less than 10 years or up to 10 years?
Well, it's up to 10 years, so by age 9 years, 11 months is eligible for the study.
Okay. All right. Thanks.
Hi.
The question I had is, as you said, myostatin in our body is like a natural mechanism that is there. So now we are doing anti-myostatin. So has there been thought towards, like the rate of muscle degeneration in every child is different. We see they're walking, the rate is different. So how do you decide what dose they should get, how high does it get, and at what point do you need to stop because they've gained the muscle strength they need, and you can't keep just increasing the muscle weight?
So, we believe that you really need to suppress myostatin to a very high degree in order to see the pharmacological effects, but clearly there is a dose-response relationship. We don't have a way currently of titrating the dose at an individual level based on a turnover of muscle or number of satellite cells or any other such measure. So at the moment it has to be sort of blind to that kind of heterogeneity of muscle turnover. We just don't have the information that we require. We are, though, obviously going to be looking at the effects of each dose independently and may, in the future, select one dose if the data are strong enough that accommodates the majority of individuals. Or we may allow a dose titration that's really been driven by establishing the safety of the drug. If there are signs that there's a big heterogeneity in the rate of response or any effect of that kind. So, I don't know whether that completely answers your question. We can't take account of that type of individual variation as we select doses at the moment, but obviously will be driven by the data if there are good reasons to do it a different way.
Thank you so much. Just one question. So this is you're considering this to be something they would have to do lifelong, or as I was asking, at some point you feel it's reached an optimum level and then you need to stop taking anti-myostatin and let the natural body course take place?
Well, that's a great question. I don't think we have the answers to that. I mean, we'll have to be driven by data on from this study and on longer-term use to see whether there's a point at which it no longer makes sense to continue this therapy. But we do think if this approach allows for the delay in some critical milestones in the disease, then it may be an important therapy. We do have plans subsequent to this study to look at a non-ambulant population and focused on upper limb strength and respiratory function. But that will be kicked off once we've established in the first instance the safety and efficacy using this set of criteria.
Thank you so much.
Hi. Okay. So, do you see this supplanting steroid treatment possibly within the near future? And then, has there been any foreseeable future where this would be in conjunction with an exon skipping process, or are we looking for this to be the baseline treatment only?
Well, for the moment, we don't have plans for a combination therapy. Obviously, you want to combine therapies that clearly have demonstrated efficacy. But there's no a priori reason not to be able to combine those therapies in the future. There's no overlap in the mechanism, there's no safety reason that we're aware of that would prevent that combination being used.
Thank you.
I had a parent ask me, she's from Brazil, and was wondering if patients from South America can travel to the US and participate in the trial. If you could give some information on that.
Well, we do have some individuals traveling significant distances to take part in this trial. The countries that we're currently enrolling in are the US, Canada, Japan, the UK, and Italy. There are some sort of legal and logistic difficulties in such a proposal. Obviously, it's very frequent travel and so on. But I think we've had some concern from investigators and their hospitals about taking liabilities on from international travel. So I think we have to go into quite a lot of detail in the individual case to evaluate whether it's really feasible. But there's no a priori reason that we wouldn't consider it.